We also look at complicated deformities that result from, got their attention, didn't I? Result from an ankle sprain. An ankle sprain is almost the opposite of the posterior tibial tendon dysfunction because it is highlighted by external rotation to tibia and simultaneous internal rotation of the foot. We have to control that in the exact same way with a brace. This is a video taken, I don't have it live on YouTube, but you can look at this. This is Kobe Bryant, who plays for my Los Angeles Lakers in Southern California, and it shows in the right-hand picture him landing on his foot, internally rotated at the foot and externally rotated at the leg. This injury took him out of the NBA playoffs 2 years ago against the Dallas Mavericks. To control these difficult motions, we apply the same principles. Prophylactic ankle bracing, even with custom bracing, is getting more and more popular in this country. When patients lose ligamentous control over the ankle, they will go on to rapid degenerative arthritis. This is a 47-year-old patient of mine who had a neglected syndesmosis rupture or sprain that went on to complete subluxation and advanced DJD of his ankle. It left him with a varus deformity in his left foot and significant pain on ambulation. His solution from the surgeons is to fuse his ankle, and that's the only solution viable, other than bracing. We made him a brace that unloaded or offloaded the medial or lateral aspect of his ankle, and even though he still looks somewhat inverted here, when we decompress the ankle joint with offloading bracing, we get rid of pain. And this can again be very gratifying. He sent me this picture a year later when he climbed Camelback Mountain with his 22-year-old son. This is the tallest mountain outside of Phoenix, right? In Scottsdale. And that guy with that terrible ankle took this picture at the top of Camelback Mountain. Very gratifying. We have very good research now, mostly published in the US orthopedic literature, showing very positive outcomes with various types of AFOs to treat adult acquired flat foot. Today there are 7 papers, some level 2, mostly level 3 research, showing rather remarkable results when these patients are braced and not operated on. For example, this study by Alvarez showed that 89% of these patients were subjectively satisfied with treatment with a brace, and 80% were successful in avoiding surgery and staying brace-free with a minimum follow-up of 1 year. This is another paper by Johnny Lin, very interesting. This follow-up was 7 to 10 years, and 60% of the patients, over 80% of the patients were fully satisfied and avoided surgery. This was the type of brace they used. It's interesting to look at these studies because, for example, in Alvarez, 80% of the patients were discontinuing the brace after 1 year of use and stayed pain-free up to 5 years later. More importantly, the majority of them avoided surgery. Recent paper published in our Foot and Ankle Surgery Journal showing that 87% of these patients with stage 2 adult acquired flat foot were able to avoid surgery. And that's a big deal for these patients who are otherwise high surgical risks. If we look at functional scoring of patients with adult acquired flat foot who either were braced or had surgery, the surgery scores and the bracing scores are almost identical. Given that fact, what would you rather have? Surgery with a high risk of complication or bracing with virtually no complication? That's why in the United States, functional bracing is really the gold standard in the treatment of stage 2, stage 3 adult acquired flat foot. Any surgeon would be considered negligent if they operated on a patient immediately with this condition without trying at least a 6-month course of functional bracing. That is the gold standard in the United States today. It is not the gold standard in the UK and Europe, and I believe it should be.